Hello friends, today we will see one important topics in sleep medicine, that is how to analyze a PSG report or polysomnography report or sleep report. This is important for those who are involved in sleep medicine. So how to report a PSG study we'll see. So in a sleep study, we should look for various parameters like sleep architecture, deep versus superficial sleep, sleep efficiency, sleep latency. What are these? So I'll discuss one by one. Apnea, hypopnea, snoring, oxygen desaturation, very important. Minimal SpO2, SpO2 before below 90%, heart rate, arousal, blood pressure, periodic leg movement. These parameters we should look in a ideal PSG report or level 1 PSG report. So to measure these data, we have to do type 1 study. Type 1 study means in lab study, in hospital study, observe study. Technician used to watch study in supervision of technician. So level 1 study, for these parameters, we are supposed to get electrocardio, electroencephalogram, EEG derivation, electrooculogram, EOG, chin electromyogram. With these three parameters, we can identify sleep architecture: superficial sleep, deep sleep. Component of sleep: superficial, N1, N2, N3, or is REM sleep. So individual sleep parameters, we can identify these channels. Electromyogram for PLM, periodic leg movement. Airflow signals for apnea, hypopnea. Respiratory effort signals, these belts. This will tell us about central sleep apnea or obstructive sleep apnea. Oxygen desaturation or oxygen saturation, pulse oximeter. You can see in this patient, this is pulse oximeter. Body position, this belt will tell whether patient is in supine position or left lateral, right lateral position. EEG, important for heart rate evaluation and ECG evaluation. And of course, video. So there should be camera in level 1 study, which will look for abnormal movement during sleep. So this is real patient in whom I am going to report sleep study. This is real patient. So this is the report of same patient. This is the first page of report. In that report, we have to that make sure that every entry should be correct, like height of patient, weight, and BMI. Technician name should be there. Later on, we can ask question what abnormal movement they have observed. We should note technician name also. Another thing is recorded time and total in bed, TIB. So what are these times? I'll discuss in subsequent slide. But in this page, you have to see that recorded time is 8 hours, which is sufficient. So by seeing recorded time in TIB, we can identify whether the proper time that the sleep recording has been done for proper time or not. It should not be less or should not be more. So this is diagnostic. Here it is diagnostic, not titration. Okay. So this is first page of our sleep report. Second thing is hypnogram. So what is hypnogram? Hypnogram is just that division of sleep stages. By eyeballing, we can identify how much sleep stage is there or how much time is there in every sleep stages. So in this page, in this that graph, you can see there's A for arousal, W for wake, REM sleep, then non-REM sleep, N1, N2, N3. So by seeing this graph, we can identify when is the REM sleep between 3 a.m. to 4 p.m., 3 a.m. to 4 a.m. When is the deep sleep is around 12 o'clock, then again 1 o'clock. So by eyeballing, we can identify which part of night is having which stage of sleep, whether REM sleep or non-REM sleep or awake. Second thing is, what is the difference between arousal and wake? It looks similar, but it's not similar. There are difference. What is arousal? Abrupt shift of EEG frequency that lasts for at least 3 seconds and at least 10 seconds of stable sleep. So there is micro arousal only for 3 seconds. So patient is not aware. If you ask patient in morning, then he will tell, no, I didn't get any arousal. I was very comfortable at night. I slept very nicely. But by seeing sleep report, you can identify there are many arousals. See, these are many arousals. So these are brief, 3 second brief. If more than 50% of epoch is covered in wake period, that is called wake. So for 3 seconds, it is arousal. Patient might not be knowing. Wake, patient is knowing everything. So arousal is partial. Patient may not be fully aware, but wakefulness, patient will be conscious, aware of surrounding. Impact of sleep, both disrupt sleep, arousal as well as wakefulness. So many arousals, they will disrupt sleep architecture, but wakefulness severely disrupts sleep. And these patients who are having more arousal or wakefulness, they will have daytime excessive sleepiness. Okay. Purpose of arousal is for restore airflow, prevent complete collapse. So while apnea or hypopnea, so if there is no arousal, patient will have prolonged apnea or hypopnea. So this is life-saving for patient arousal to terminate the apneic or hypopneic event. Okay, but wakefulness is for restore airflow and fully aware of disruption. Example, brief twitch, EEG shift. We cannot identify very easily. And patient is fully awake and conscious in case of wakefulness. So we have to identify both. This is W, wake. It is longer period as compared to arousal. Arousal for seconds, 3 seconds, 4 seconds, like that. Okay. So this is for normal sleep, normal hypnogram for normal patient. And that was for our patient. And this is for normal patient. So normal patient, if you divide sleep period in three parts, first half, second half, third part. So in first half, there is more N3 non-REM sleep or deep sleep. So you can see this is N3. Okay. So N3 is more in first one third of sleep period. So as sleep progresses, N3 reduces. In morning time, there is no N3, no deep sleep at morning time. But if you see REM sleep, REM, the red one is REM sleep. So if you see REM sleep, it is more in last one third of sleep and very less in first one third of sleep. So as sleep progresses from night to morning, N3 decreases, REM sleep is increases. Usually REM follows non-REM sleep. Okay. So first REM sleep period may be less than 10 minutes. You can see it is 10 minutes, but last may exceed 60 minutes. Last one third of night, it may up to 1 hour REM sleep. So this is hypnogram. So awakening after full night sleep is usually from REM sleep. This is not universal, but usually patient usually get awake after REM sleep only in morning. So this is normal sleep hypnogram. So when patient is lying down on the bed, try to sleep, is wakefulness, then goes to N1, then N2, then N3. Again N3 to N2, then REM. So this is not fixed period. It changes in individual to individual. This is normal hypnogram. Coming another part of our sleep report, this is sleep scoring data. It tells sleep structure, sleep architecture, how much patient slept, how much recording has been done. So it has many parameters: total sleep time, sustained sleep efficiency, total sleep period. So what are they? We will see one by one. So in this graph, you can see this is the start of our recording. So when the technician is doing hooking, after completion of hooking, patient is switching on the machine. That starts recording. And when in morning time, when patient awake, technician is going inside the room and switch off the machine. So that time from start of machine to completion, that switch off machine is total recording time. So patient has started machine and asked patient to lie down and try to sleep. Okay, so from that time, that is called light of time. So light of time is when patient is ready to get sleep. Recording has been started and technician asked patient to lie down and try to sleep. That is light off. When patient has started try to sleep. And light on is when technician enter in the morning and switch on the light. Okay, that is, so that time is called time in bed. Means how much time patient was there for sleep in the bed. Okay, say for example, if I am lying down on bed at 10 p.m., it is not necessary that I will get sleep at 10. Say for example, if I get down at 10, then I get if I get sleep at 10:30, so half an hour is sleep latency. Half an hour is sleep latency. So that is the first sleep onset. I lie down at 10 p.m., but my first sleep came at 10:30. So this half an hour is my sleep latency. Okay, so my first sleep is 10:30 and I wake up at 6:30 morning. So that is my sleep period time. Okay, time in bed is different, sleep period time is different. Sleep period time is when I slept first time to time when I got up in the morning. It is sleep period time. Now 10:30 I slept finally, but night 1 o'clock I woke up for washroom. Again 2 o'clock I woke up because of mosquito. At 3 again I woke up for some other reason. 4 again I woke up for some reason. So these are sleep disruptions. Okay, not effective sleep disruption. This is called VASO, wake after sleep onset. After sleep has started, then patient is getting up. That is called VASO, wake after sleep onset. So these are the sleep disturbances. So I got sleep at 10:30. I got up this time, this time, this time. So if you minus this period, sleep disruption, the sleep will remain. That is called total sleep time. So total sleep time means my REM sleep, my non-REM sleep, N1, N2, N3. That sleep is total sleep time. Okay, if you add VASO in total sleep time, that will become sleep period time. Means first onset of sleep to morning when I wake up. Time in bed when I lie down the bed for sleep, but I didn't get sleep. And total recording time when machine was on. That is total recording time. So you must understand this all these three, all these periods. Okay, so sleep latency is the time from light off until the patient enters into sleep. I lie down at 10 p.m., but I got sleep at 10:30. That is my sleep latency. Normal individual, it should be 15 to 20 minutes. Okay, if somebody is sleeping before that, say for example, if somebody is sleeping in 5 minutes, it means patient has shorter sleep latency. It is abnormal. Why abnormal? Either patient is having sleep deprivation. Say for somebody is doing night duty and another night he will fall asleep. As soon as he will lie down on bed, he will get sleep. Short sleep latency. Or it is common in insomnia patient. Vaso, wake after sleep onset. These areas, mosquito, washroom. This is the total amount of time spent wake after initial falling sleep. Okay, so these are the sleep architecture. Okay, so in our patient, we are seeing that total sleep time. Total sleep time means REM, N1, N2, N3. This is 6 hour 22. How much recording time? It was 8 hours. Out of 8 hours, he slept 6 hour 22 minutes. Okay. Total sleep period means total sleep time plus VASO, wake after sleep onset. If we combine both, then it is 7 hours 51 minutes. Okay. So what is sleep efficiency? total sleep time divided by total time in bed. I lie down at 10 o'clock morning, 6 o'clock. That is my time in bed. But how much slept? That is total sleep time divided by total time in bed is sleep efficiency. It should be more than 85%. Sustained sleep efficiency, total sleep time upon total sleep period. I am removing sleep latency. If I lie down at 10 o'clock, I slept at 10:30, half an hour I am not including. That is sustained sleep efficiency. So in this patient, sustained sleep efficiency is 81.2%. Slightly less because it should be more than 85%. Okay, so two efficiencies there: sleep efficiency, sustained sleep efficiency. For easy, you remember sustained sleep efficiency 81%. Okay, sleep latency 8.9 minutes means after lying down uh, on the bed, patient got sleep at after 8.9 minutes. So this is important. This is shorter sleep latency. Then we have to look for REM latency because many patients they are having very less REM sleep onset. For example, in case of narcolepsy, whenever patient is lying down, directly goes to REM sleep. That is called SOREM, sleep onset REM sleep. So we have to look REM sleep onset also. So normal it should be 90 to 110 minutes. Okay, if it is less, it is abnormal. So sleep onset REM sleep is seen in narcolepsy. So REM, sleep onset REM. When patient lie down, straightly goes to REM sleep. This is narcolepsy. Now, individual sleep stages. How much N1, how much N2, how much N3. This is graph of normal individual. So if you divide sleep into 4 phases, 1/4 time is REM sleep, is 25%. This is mean, not a exact, plus minus 25%. Okay. Out of 75%, 50% is N2. Now how much remaining? 25%. Out of 25%, N3 is 15%, N1 and wake is 55%. This is normal sleep architecture of a normal ideal patient. Okay. But in our patient, REM sleep is 15.3. It should be around 25%, little decreased. N1 is 12%. N1 is superficial sleep. This should be 5%, little increase in our patient. N3, most important is N3. N3 is normally 15%, but our patient is 26%. It is good. So these sleep stages are not fixed. It is very individual to individual. It varies with ages also. In young individual, there is more deep sleep. In older individual, is less deep sleep. So it varies from ages also and between individual to individual. In our patient, deep sleep is 26%. This is deep sleep, N3 sleep. Okay, this is sleep architecture. Now coming to important part, respiratory analysis. For that, we are doing sleep study. Okay, so in that we have to look for apnea, hypopnea, and rera. Apnea, hypopnea, rera. So what is this? This is apnea is flow reduction more than 90% for more than 10 seconds. So for patient, we are making them understand like that somebody is that blocking your throat. Somebody is pressing your throat like that. If there is reduction of flow by more than 90% for 10 seconds, it's called apnea. Okay, hypopnea is your throat is blocked, but airflow reduction is more than 30%, not 90%, 30%. But because of 30% flow reduction, there is 3% oxygen desaturation or there is arousal. So 30% reduction in airflow with either 3% reduction in SpO2 or with arousal is called hypopnea. Rera is if airflow obstruction is there but less than 30%, but patient is getting up, is arousal is there. So flow reduction less than 30% with arousal is called rera. respiratory effort released arousal. Arousal should be there. This is key point. Okay. So if you combine all these things, it will become RDI, respiratory disturbance index. Means apnea, hypopnea, rera per hour. In 1 hour, how many apnea plus hypopnea plus rera? If you combine apnea, hypopnea only, it will become AHI. Okay, AHI, how much apnea, how many hypopnea per hour of sleep. This is AHI. So, according to AHI or RDI, we defined OSA patient as mild, moderate, severe. 5, 15, 30. You have to remember three things. 5, 15, 30. Less than 5 is normal. 5 to 15 is mild. 15, 30 is moderate. More than 30 is severe. That is AHI. But RDI, instead of 5, we take as 10. Less than 10 is normal. 10 to 15 is mild. 15, 30 is moderate. And more than 30 is severe. This is how we classify OSA in mild, moderate, severe according to AHI and RDI. In our patient, this is report of our patient. So you can see there is apnea, obstructive apnea, how many? 90. If you see index 14.1, mixed 0.2, central 0, undifferentiated 0. Total apnea index is 14.3. Okay, per hour 14.3. Hypopnea is 32.1 in 1 hour. Index. So AHI index is 46.4. If we combine RERA means flow limitation. In our machine, it is giving limitation, flow limitation, 1.1. The total RDI is 47.5. So our patient is having severe obstructive sleep apnea because AHI or RDI is more than 30 per hour. Our patient is having severe obstructive sleep apnea. Let's see other parameters. So same RDI or AHI, we can compare REM sleep and non-REM sleep. Same thing. Apnea, hypopnea, RDI, HDI, flow limitation, RERA. We can compare REM versus non-REM. So we can see which stage is having more respiratory disturbances. Maximum apnea duration, maximum hypopnea duration. Okay. So we can see individually in every sleep stages also. Important that we have to see these parameters in various sleep positions. How many in supine position, how many in left lateral, how many right lateral, how many prone. Usually patient don't sleep prone in laboratory, not upright. Okay. So we have to compare supine versus non-supine, but RDI. Okay. So RDI in supine position is 57, non-supine is 49 in this patient, in our patient. Okay. If supine AHI is more than twice of non-supine position, means in supine position AHI is more than 2 times of non-supine position of AHI, then this is called positional obstructive sleep apnea. Treatment is little different than as non-positional obstructive sleep apnea. We can try various positional therapy on this patient. So we have to identify whether patient is having positional sleep apnea or not. In our patient, there is no positional obstructive sleep apnea, right? Now, another good parameter is oxygen saturation. As you know, when there is apnea or hypopnea, there is flow reduction, means the amount of air is going inside is less amount. Okay. If less amount is air going on, then oxygen will drop because less oxygen inhalation, body oxygen will come down, spo2 will come down. So if there is reduction of spo2 by 3%, this is called desaturation. If baseline is 95, if reduction is by 3%, say for example 95 to 92 or 91, it means there is desaturation. So we have to see in 1 hour how many desaturations are there. In this patient, there is 73.6 desaturation index, means 73.6 times his saturation drops by 3% as compared to baseline. This is very significant. And his SpO2 is dropping and going up to 67. So less, 67%. And if you see that below 90%, why we are taking 90%? Because 90% is critical for functionings of organ. So at least 90% saturation should be there for functioning of organs. In this patient, 346 desaturations are there, which are below 90%. If you see below 80%, 79 desaturation is there. So severe hypoxia is there. So this is important parameter, SpO2 time below 90%. It means how much time patient was slept when his SpO2 was below 90%. How much time? This is 2 hour, 2 hour 34 seconds. The percentage of sleep 31.9. It means 2 hour patient was there when his SpO2 was below 90%. This is very significant. Other parameters you can see, but not so important for our reporting purpose. Okay, so we have to see oximetry data. Severe oxygen desaturation has been classified when oxygen desaturation is below than 90%. Okay, so ODI, what it show, or mean SO2, if it is less, it shows chronic type of hypoxia. And chronic type of hypoxia, there is chronic complications of OSC like pulmonary arterial hypertension or core pulmonary. If SpO2 is dropping below 80% or 90%, that causes acute complication of OSC like coronary artery disease, stroke, hemiplegia, or MI. These are acute complications because of sudden drop of oxygen below 80%. So this is oximetry data. Now coming to heart rate. When oxygen is getting reduced in the body, every organ is malfunctioning. Heart rate malfunctioning or not, we have to identify. So there are certain heart rate parameters. In heart rate parameters, what we are seeing, sinus tachycardia. If heart rate is more than 90, is sinus tachycardia. If heart rate is less than 40, this is sinus bradycardia. Asystole, when cardiac pause is greater than 3 seconds, cardiac asystole, death, finish. If tachycardia is there, then we have to identify narrow complex or wide complex. Narrow complex, if heart rate is more than 100, but QRS complex is less than 0.12 seconds. This is narrow complex tachycardia. Wide complex tachycardia, when QRS complex is more than 0.12 seconds. This is wide complex tachycardia. Arterial fibrillation, irregular QRS complexes associated with consistent P wave replacement. Arterial fibrillation. So in any sleep study report, we have to see heart rate. If it is normal or abnormal. If it is normal, then okay. If abnormal, either bradycardia if less than 40, tachycardia if more than 90. Okay. If it is more than 100, we have to look for QRS complex. If QR complex is more than 0.12, it is wide complex QRS wide complex tachycardia. If it is less than 0.12, it is narrow QRS complex tachycardia. So this is how we have to look for heart rate variables. In our patient, luckily there was no wide complex narrow complex tachycardia, but arrhythmia index was 11.2. It means in 1 hour 11.2 times heart rate variability was there, less more, less more, less more. Maximum heart rate was 93, minimum was 52, average was 63. So this is the heart rate parameters. Now coming to periodic limb movement, means the shaking of legs at night time. So there are criteria. What's criteria? If PSG demonstrating highly stereotyped repetitive limb movement, okay. So this is PLMS or periodic limb movement. It is should be less than 15 for adult. If it is more than 15, it is abnormal. It causes disturbance of any type like sleep disruption, then this is abnormal. It is not better explained by another medical, psychological, or substance abuse disorder. So if it is there because of sleep, then only we label as PLMS. It should not be there psychological or any other things. Then only we call as PLMS. Okay. So in our sleep report, we are concerned with three parameters. We have to see three parameters. Total limb movement means just shaking of legs. So in our patient, leg movement is there 16.9 in 1 hour. But if we see periodic limb movement, it is 9.2. So more than 50 is abnormal. 15 is abnormal. So this is 9.2, less than 15. It means we can take it normal. But one more important thing is how much PLM is causing arousal. That is sleep disturbance. Our patient 1.7. This is PLM with arousal index 1.7. So in 1 hour, 1.7 times it causes sleep disruption or arousal. This is PLM. Okay. So PLM, what the etiology of PLM? It is narcolepsy, restless leg syndrome, iron deficiency, diabetes, REM sleep behavior disorder, drug induced. These are the causes of PLMS. Okay. So we have to correct. Another thing is video recording. You know that in level 1 study, type 1 studies, we are doing video recording and technician is monitoring full night. Why? Because we can identify leg movement and parasomnias like sleepwalking, sleep talking, sleep running, bruxism, REM behavior disorder. Somebody is running, open the window, patient is shaking his head, even seizure activity, epilepsy, we can see in video. That's why camera is important in level 1 or type 1 study because we can identify various parasomnias. Now important is snore. How much patient is having snoring? Because the main complaint by which patient present is snoring. Okay, and snoring is inspiratory event like inspiratory event. Okay, so this is snore index 422. Okay, so what is snore index? Number of snore in each body position during total sleep time. In 1 hour, how much snore is having? 422. And this is snore episodic. Snore episodic is sum of all time interval between two snore events if they are less than 10 seconds. So we have to see how much percentage is there snore episodic. So when patient slept at say for example 8 hours, out of 8 hours 37% was there with episodic snoring. Okay, and 1 hour patient is having 422 times snoring. So if you tell patient that 422 times you have snored in 1 hour, he will be surprised. Okay, but you should not surprise. Why? Because in 1 minute we are taking breath around 15 times. So if you see our breath count in 1 hour, then 15 multiplied by 60, it is 900. So we are taking inspiration and expiration 900 times in 1 hour. So out of 900, patient is having 422 times snore. Every time he is taking inspiration, he was having snore 422 times. So this is quite significant. Now, one important parameter, that is arousal, because frequent arousal at night time will cause daytime somnolence or daytime sleepiness. So how much arousal patient is having at night? Okay, so we are not bothered about spontaneous arousal. MA for micro arousal. Micro means patient will get up for 3 seconds or more, and patient is not knowing that he is getting up frequently. If you ask patient in morning whether you have wake up or not at night, he will say no, I had sound sleep, I didn't wake up at all. So that's why they are called micro arousal. For few seconds, patient will not tell that he was having arousal. So we are bothering about respiratory micro arousals because of apnea, hypopnea rara. How many times patient got up at night? Desaturation because of low oxygen. How many times patient got micro arousals? Then snore. How many times because of snoring? 5.3. Okay, and many times we take PLM also 1.7 times, and flow limitation 0. So these parameters, four parameters: respiratory, flow, desaturation, and snore. So we have to count these micro arousals. Okay, so it varies with age. Like young patient, they are having less amount of micro arousal. In older patient, they used to have more arousal index. Okay, so sleep distribution normal is 10 to 25, depends on age. Okay, in our patient, if you add 17.5, 32.9, 5.3, it will come 55.7. The patient is having very high arousal index, means there is lot of sleep disruption at night. That's why patient is having daytime somnolence, daytime sleepiness. That is very dangerous. So now coming to pulse transit time. This is new terminology, so I'll try to explain. So our heart rate is generating at the heart aorta, and pulse is coming from heart to radial artery. It's traveling from heart to radial artery. We are palpating, and we are telling our pulse is 90 per minute. Okay. So time taken for pulse to travel from heart to periphery is called pulse transit time. From heart to periphery, radial artery. Okay. Heart means aortic valve. The time taken pulse waveform from travel to from aortic valve to periphery, usually finger. This is called pulse transit time. It measures R wave in ECG and pulse oximeter photoplethysmography. The time taken from R wave to photoplethysmography is pulse transit time. Okay. So it is indirect marker for sleep fragmentation. What happens when we are sleeping comfortably? There is parasympathetic activity. We are sleeping very nicely. But when we have arousal may be because of apnea, hypopnea. When we have arousal, our sympathetic activity get increase. Okay, when sympathetic activity get increase, there will be less time travel from heart to pulse, because while sympathetic activity will activate, pulse will go very fast. There will be tachycardia. The pulse will go fast from heart to radial artery. Time travel from heart to radial artery will get reduced. There decrement of pulse transit time while arousals. It is indirect marker for sleep fragmentation. So PTT drop was defined as fall in PTT curve for more than 15 seconds, lasting for at least 3 seconds and most for 30 seconds. If transit time is decreasing by 50 seconds, this is significant. Okay, and drop index, PT drop index is number of drops in PTT that occurs per hour of sleep. In 1 hour, how much time the PTT is getting reduced. So if you see this report, the decrease index or drop index is 37.8. It means 37.8 times PTT has reduced. And maximum pulse transit time is 392, means 392 millisecond from heart to peripheral artery. Minimal is 264. This is not very important for us. Important for us is 37.8 index. And another important thing is this PTT is getting reduced because of what? Because of respiratory PTT or spontaneous. So in our patient, respiratory PTT means PTT reduced because of respiratory event, let it be apnea, hypopnea, rara. It's around 14.5. Because of flow limitation, 0.2. Because of PLM, 0.3. Because snore is 12.9. This is important for us, these 3 or 4 parameters. We are not bothered about 9.7, which is spontaneous. So by graph, you can see this blue one is respiratory and this green one is snore. This is important for us. For our patient, index is 37.8. Right? Now coming to BP. BP, whenever there is arousal, BP is getting up because of increased sympathetic activity. So how many times BP is getting increased? By 12 mmHg within 3 to 30 seconds. So BP is increasing by 12% for 3 to 30 seconds. That is called BP increase index. That was drop index, but increase index. In our patient, it is 31.4. It means 31 4 point times his BP got up by 12%. Okay, by this we can see that maximum systolic pressure, minimum systolic pressure, maximum systolic pressure, and maximum increase in systolic BP. So these are parameters, but not important for us. Important is increase index. Okay, and another important thing is this BPs got increased because of what? Because of respiratory event or spontaneous. So we are bothering about BP increase because of respiratory event, apnea, hypopnea index, flow limitation, and snore. Okay, we are not bothered about spontaneous. In this graph, you can see the blue one, maximum increase because of respiratory event, apnea, hypopnea, rera, and snore, green one. We are not bothered about spontaneous. Okay, so this is blood pressure fluctuation, and this last is blood pressure statics, means static blood pressure. Okay, so mean systolic pressure 122, diastolic mean 85, a map is 97. Okay, so important for us is index and respiratory, snore, and flow limitation. These are the important for us. This graph is important, we have to mention in our report. So this is last part of our report. So by last, this is like a chart. By eyeballing this chart, we can see our patients having severe problem, moderate, or mild. So green is normal. Patient had normal sleep latency, sleep stages, and red one is severe. Patient has severe AHI increase, severe snoring, severe desaturation, severe PTT, severe arousal. So our final report, we have to mention these parameters: sleep efficiency, AHI index 46.4, snoring index, SpO2 minimum, SpO2 below 90%, HR minimum, HR maximum, arousal index, average BP. And based on AHI, we have to give report mild, moderate, severe, 5, 15, 30. So our patient will fall in severe obstructive sleep apnea. Why? Because AHI is 46.4, but which is more than 30. Severe obstructive sleep apnea with severe desaturation. Okay, so this is our report. So this is the report we are giving to patient. Okay, so in patient report, we have to mention important parameters like sleep efficiency, RAM, how much RAM, how much deep sleep, how much latency, AHI, RAM, non-RAM, oxygen parameters, heart rate parameters, snore parameters, arousal index, and BP fluctuation. So these parameters we are supposed to mention in sleep report, and final impression is patient diagnosis like severe obstructive sleep apnea with severe desaturation. Okay, then patient we have to advise sleep hygiene, tight study, and another important is ABG, because in case of overlap syndrome or obesity hypoventilation syndrome, there is increase in carbon dioxide. We have to identify in this type of patient because treatment mode is different. So this is how we are giving sleep report to sleep patients. So I hope you understood this lecture, and this is important for those who are dealing with sleep patients. So if you want to know or if you want to see my previous videos in Hindi, you can scan this QR code. So if you like this video, please like it, share with your friends, and we will see you with new video. And in second part of this video, I'm going to show you titration report of same patient. So please see my next video on titration. Thank you very much.